that is fine. I just wanted to make sure I did it right. Okay, that's fine. So what I'll do is I don't want to make it a formal presentation because I'm sure you guys have already discussed OSA a lot in yesterday. So what I will try and do then is I will kind of project what is different in pediatric obstructive sleep apnea when compared to adult sleep apnea. So I think that will probably be, and I will direct it towards not necessarily pulmonology kind of group, and therefore everybody is in sync with what I'm trying to say. Is that okay? Can I do that?
Sir. It's okay.
Perfect. Okay, thank you. And wherever required, I do have a lot of slides in my general talk. If I need something, I can always pull it up and show it to you. No problem. Okay. So first of all, pediatric obstructive sleep apnea is not uncommon at all in children. Um, and if you look at all epidemiological studies, snoring especially is almost 25 to 30% common in children in below the age of 12 years of age. So I think 1 in 4 kids snore. But what is important in pediatrics to understand is not all children who snore have obstructive sleep apnea. And therefore, it is important for us to differentiate that. Now, if you take 25% as the total number of children who snore, only about 6 to 8% of them have what we call as um, regular snorers or habitual snorers. And how do we define habitual snorers? We define habitual snorers as those who snore for at least 4 days in a week consistently. So if somebody is snoring regularly, most mothers otherwise will come and tell you, oh, my child snores when he is tired, when he has an upper respiratory infection and things. But we are not worried about those kids. We are worried about kids who persistently snore at least 4 days in a week. Now, if you take this subset of habitual snorers, within that subset, only about 4% of them have what we call as obstructive sleep apnea. So if you take a big chunk of snorers, the children who end up having obstructive sleep apnea is very, very narrow and very small. And therefore, it is very imperative for us, though we start with a history of snoring, it is imperative on us to make sure that they actually have obstructive sleep apnea before we treat them. Now, just to recap, there is, basically, why don't I just run through one of my formal slides, but I won't go through that. Can I just take a minute? I'll run through my formal slides. It might help the audience.
Yes, sir.
So sleep disordered breathing is not a single kind of 1 minute. Yeah, I got this. This is not meant for this particular thing. I had a previous set of slides which I'm sharing. So in between some of the slides, I might fast forward. So please bear with me. This is only to give a pictorial representation so that people are able to understand what I'm talking about. So sleep disordered breathing is not a single entity, and it's a spectrum. You have normal children on one side, and the other extreme spectrum is obstructive sleep apnea. In between, you have the whole spectrum of children with primary snoring, obstructive hypoventilation, upper airway resistance syndrome, etc. And adults, I'm sure, will be very cognizant of diseases like upper respiratory upper airway resistance syndrome. Not very common in children, but is known to have. And therefore, if you look only for obstructive sleep apnea, you're in trouble because you have not taken care of the rest of the spectrum. So we know obstructive sleep apnea is recurrent blockage of the upper airway. And there are two major things that in pediatrics obstructive sleep apnea is because of. So here you have both anatomical factors and functional factors. So this is slightly different than an adult kind of thing. So in most children who are otherwise normal, especially children between 2 to 12 years of age who are non-obese, the commonest problem is adenotonsillar hypertrophy. And that is what is usually the main problem that is seen. And if you there is a lot of studies which have been done on upper airway in children with obstructive sleep apnea. Not only do we see anatomical changes, which means you can have adenotonsillar hypertrophy, sometimes we find that the facial characteristics of children with OSA differ from facial characteristics of children without OSA. For example, people have done interpalatine distance, looking at the bite, overbite, underbite, maxillary hypoplasia. All of these subtle changes are already there even before children actually present to us with obstructive sleep apnea. And if you look at the, there's a fine balance between structure and function in upper airway. We always worry about structure. We all know that. So anything which causes airway obstruction from nose to the larynx, which includes cornal atresia, nasal polyps, allergic rhinitis, nasopharyngeal adenotonsillar hypertrophy, children with maxillary hypoplasia, children with retromandible syndromes, upper airway syndromes. All of these children definitely have high risk for obstructive sleep apnea. But the group that is often forgotten are children who look normal but have neuromuscular problems. They might just have a little bit of hypotonia. For example, children with Down syndrome have significant hypotonia, which puts them at high risk for obstructive sleep apnea. Children with neuromuscular disorders, again, puts them at a very high risk of obstructive sleep apnea. So it's very important to think of OSA when you see a child with the neuromuscular disorders. So how do we diagnose OSA? So, typically as an adults, history is something that we always look at, but the key thing to understand is children are different from adults in one primary aspect. That aspect is, if adults don't sleep in the night, they tend to have excessive daytime sleepiness, and you will see them sleeping a lot in the daytime. Whereas pediatrics, if they don't sleep in the night, they are hyperactive in the daytime. So they do not have excessive daytime sleepiness. They are hyperactive in the daytime. In fact, a lot of them get a diagnosis of ADHD rather than OSA, and therefore it is mistaken. That's a primary difference. And this difference goes away when you come to an adolescent kid. If you see an adolescent who is 12, 13, 14 plus, who is very, very obese and has nocturnal obstructive sleep apnea, that age group tend to simulate like adults, and they tend to have excessive daytime sleepiness. So this actually prompted David Gozal. He is one of the fantastic researchers of sleep in pediatrics from the US. He classified obstructive sleep apnea in children into two subtypes, type 1 and type 2. Type 1 are children who are otherwise normal, 2 to 12 years of age, who have adenotonsillar hypertrophy, who have failure to thrive, who are thin built, and who have adenotonsillar hypertrophy. They are hyperactive during the daytime. Type 2 are children who are older, 12 to 14, 12 to 18 years of age, children who are obese, children who have obstructive sleep apnea, and children who tend to have excessive daytime sleepiness. But this particular classification is not universally accepted. There is still some gray characteristics going between the two, and therefore it's just important for us to know that in younger children, don't look for excessive daytime sleepiness. So if you look at the history here, the nocturnal symptoms are very similar to what you would have in an adult. Whereas the daytime, they can have dry mouth, daytime somnolence sometimes like in adults, but more often it is hyperactivity and poor attention. Poor school performance. So if if a mother comes to you with history of saying that school's performance has been decreasing over the last couple of years, then OSA is one of the causes that you need to look at. The other big thing that you also need to look at, which is not is enuresis, nocturnal enuresis. We now know that there is a big interaction between sleep and nocturnal enuresis, and children with obstructive sleep apnea tend to have persistence of nocturnal enuresis, and that's a red flag to ask for OSA. Physical examination, the characteristic facies that we call as adenoid facies is very, very typical of children with OSA. Long philtrum, thin nose, long face. If you look at the palate, it will be very, very high arched palate. And if you look at the side of the face, you'll find a little bit of retrognathia, right? And if you measure the blood pressure, usually there might be slight systemic as well as pulmonary hypertension, as the case might be. So what sort of investigations can we do? The investigations that we can do for these children are many. Of course, like adults, pediatrics has also got its own set of questionnaires. We do have some standardized questionnaires available for pediatrics, but none of these questionnaires seem to be very highly sensitive and specific. In fact, the best sensitivity is 80%, specificity is less than 60%. And therefore, at best, questionnaires are mainly a screening tool in pediatrics, and we do not rely on questionnaires for diagnosis. That brings us to the next thing that we can do, that is audio taping and video taping. So you can imagine today with smart world and smartphone technology, every parent has smartphone in their house, and they will often record the child snoring or child sleeping and bring it and show it to you. Now the question is, how sensitive are these? And again, unfortunately, the studies which have been done are quite old, in 1990s, and people have shown both audio as well as video are not great in diagnosis of obstructive sleep apnea. And this is because we all know OSA is worst during REM sleep. And we also know REM sleep is the maximum during the later half of the night, during early morning hours. That is the time when most parents are themselves sleeping. So the recording usually is done in the first half of the night when the children don't have such severe OSA. That is why if you do an audio and video taping, you should tell parents to record the most significant component of snoring, which might mean that they have to wake up in the middle of the night and do a recording later. I'm sure there is a lot of potential for audio taping and video taping because of technology has changed so much in the last 15 years. And therefore, I think we need to keep an open eye at this point of time. A lot of people do a lateral X-ray of the neck to diagnose adenoidal hypertrophy. Let me burst that myth and tell you there is absolutely no value in doing a lateral neck X-ray. An ENT doctor might do a lateral neck X-ray before the surgery just to see if the adenoid size and the contour and the bony prominences, etc. But for us to diagnose obstructive sleep apnea, we don't need to, because there is very little correlation between tonsilloadenoid size and severity of OSA. A child can have a normal or a small adenoid and have severe OSA, or a child can have a big adenoid and no OSA. So there is absolutely no correlation. Again, laryngoscopy is not something routinely done. The ENT doctors might do it before surgery just to ascertain the position and the size so that they can be adequately prepared. So two common things which are done for children is to diagnose obstructive sleep apnea is pulse oximetry, and the other one is sleep study. I know all of you as adult physicians might be doing a lot of sleep study, and I'm sure I saw some discussions on that in yesterday's topics. So I will concentrate on a pulse oximetry, which is essentially done more in pediatrics. And here what we do is we know children desaturate with their obstructive events. And therefore, we tend to measure overnight saturations and then record them. The difference that I want to tell you is we do not record with the same pulse oximetry machine that we use in the hospital or in the ICU. Those pulse oximeters have very long averaging times. It takes about 12. So the pulse oximeter takes a reading every 12 to 15 seconds. And therefore, even though it looks as if when you look at a pulse oximeter, it looks as if the pulse oximeter is giving you beat to beat saturation. It is not. It is averaging saturations every 12 to 15 seconds and giving you a number. So if you have a child who has intermittent hypoxia, which just lasts for a few seconds and goes back to baseline, then those long averaging times will miss it. And therefore, the pulse oximeters like Massimo actually have short averaging times of 3 to 5 seconds, and that is what we tend to use. And these pulse oximeters with low averaging time also have ability to record overnight events and store it within a hard disk within the oximeter itself. And the next day morning, you connect it to your computer, and then the whole data is shifted, and then you get a nice analysis trying to tell us, how much time the child spent saturation below 92, above 92, etc., etc. You will get a very good result of what has happened overnight. It is important to know that, this is the reason why I showed you that there is a spectrum of sleep disordered breathing. If you look purely for hypoxia, you're picking up only the children with severe obstructive sleep apnea. Whereas, so if you have a positive saturation monitoring study, you know the child definitely has a problem. You can send him to the ENT for surgery. However, if a child has normal pulse oximetry, it does not rule out obstructive sleep apnea syndrome in children. So this is how a report will look like. It will tell you how much of time the child spent below a particular level, and the total amount of recording time and things like that. So it is very useful for us. And these are how the records, I'm just showing you a clip shot of, you can literally see the raw data on graphs and decide whether they are good graphs or artifacts, and then decide on what you want to do. Okay, so the key thing is the gold standard as of today is polysomnography. I don't want to talk too much on this because I'm sure it has been discussed. Polysomnography is basically a lot many. It's a gold standard. It is polysomnography, so you would record many channels while the child is sleeping, and you try and see whether the child has respiratory events, which I will talk to you in a short while. I don't know. No. Okay. So the events that we record are very similar to the adult events. We record obstructive apneas, obstructive hypopneas, and hypopnea again is defined. Obstructive apnea is defined slightly differently in pediatrics when compared to adults. I'm sure adults have a minimum of 10-second period that they need to have decreased flow. Whereas in pediatrics, we don't have a definitive time. It depends on the respiratory rate of the child. So we define apnea as loss of airflow from the nose lasting for 2 respiratory cycles, which means in an older child, it might be 10 seconds or more. But in a very young child, for example, if a child is breathing at 60 times a minute, that means 1 respiratory cycle is only 1 second. Therefore, 2 seconds is enough to qualify somebody as obstructive sleep apnea. So that's the main difference. So we recognize obstructive sleep apnea and hypopneas. Hypopnea again defined as loss or drop in airflow to less than about 30% from baseline, and associated with either arousal or desaturation. Okay, so this is what we tend to do, and we calculate obstructive sleep apnea index, OAHI index. Again, here pediatrics differs in the main way that I think adults say anything of OAHI or AHI of less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, anything more than 30 is severe. That is adult classification. Whereas in pediatrics, we are a little bit more strict. The threshold is lower. Less than 1 is normal, 1 to 5 is mild, 5 to 10 is moderate, and anything more than 10, we call it already as severe obstructive sleep apnea. So that is where pediatrics differs from adults again. A lot of people have looked at biomarkers to diagnose obstructive sleep apnea. In fact, David Gozal's group looked at exhaled breath analysis. They looked at a lot of urinary proteins and serum proteins. But unfortunately, these kind of studies have not been replicated in any other part of the world. Everybody, whoever has tried it hasn't been useful. And therefore, at this point of time, we do not use biomarkers. But if you can imagine, it is useful, right? Because sleep apnea is not just uh, equal to obstructive apnea, a hypopnea index, right? A index is just looking at some values, whereas sleep apnea, you are worried about the end organ morbidity because of apnea, and the sleep study will not record end organ morbidity. And therefore, we need a little bit more finer thing to look at how we can measure whether OSA is causing the problem to the child. And that study, that kind of investigation, we are still looking forward to. Biomarkers is certainly one step forward, but a lot of people are looking at other angles. Now, in a child who is completely well, the treatment of choice in children with adenotonsillar hypertrophy, as you can imagine, is adenotonsillectomy, right? And this has been for ages. If you look at even 150 years back, there is a beautiful record of people wanting to show that even there they realized that children with obstructive sleep apnea have their cognition involved. He says here that they look stupid. Of course, you can't talk with those words today. We will get thrown into jail. But basically, they recognize that obstructive sleep apnea causes difficulty to cognition. And they also recognized that surgery actually affected the improvement of these children with obstructive sleep apnea. So that is not new. But what is new is the fact that even though we know adenotonsillectomy is the correct thing to do, so we now know that previously, about 5-10 years back, we used to subject them to adenotonsillectomy and send them home. But today we know that less than 30% of children are completely normal after adenotonsillectomy. About 60 to 70% of kids have residual obstructive sleep apnea after adenotonsillectomy. And this is a beautiful study that I wanted to share. This is from Taiwan, Yu Shuang. And basically what she did was she collected a set of children, and then she did baseline studies and did adenotonsillectomy, and then did sequential polysomnographies at 3 months, at 6 months, 1 year, 2 years, and 3 years after adenotonsillectomy. The key point to take away from this is a majority of children dropped their AHI from 13 to 3.7. So they really dropped significantly after surgery. But if you look at the end of 3 years, they had all gone up to a mean average of 6.8, 6.5, which meant even though you respond very well to adenotonsillectomy initially, over time, there seems to be a recurrence of obstructive sleep apnea, which is what we need to understand. Right? So we need to understand that children with obstructive sleep apnea, the first line of investigation is definitely adenotonsillectomy. And if they have recurrence, or if they have other characteristics like structural problems, facial dysmorphisms, or if you have children with syndromes, etc., or neuromuscular diseases, then in those children, our first line of choice is also BiPAP or CPAP like adults. So another major difference between adult and pediatric: in adults, your first line of choice is CPAP. In pediatrics, the first line of choice is adenotonsillectomy. And in some situations where there is residual OSA after surgery, or if there are structural problems and neuromuscular problems, we tend to use CPAP and BiPAP. This is one of the things that I wanted to say. I think the organizers were also wanting me to talk about a kid who is not able to sit and has OSA, which meant I think they were wanting me to talk a little bit on OSA in association with children either with neuromuscular, which I've already spoken, and also children with ADHD and autism spectrum disorder. We find that children with neurodevelopmental disorders have a very high incidence of obstructive sleep apnea. Now, I've told you obstructive sleep apnea tends to have hyperactivity during daytime in children, right? So they get confused with ADHD. And opposite is also true. ADHD can have significant obstructive sleep apnea. So these two kind of feed off to each other, and that is where the difficulty in diagnosis comes along. We know children with obstructive sleep apnea, ADHD, have multiple problems in relation to sleep. They all have difficulty getting to bed in the night, initiating sleep. They have no rhythm or cycle of sleeping regularly every day. So the rhythm is upset. They have frequent arousals in the night, and they can also have significant insomnia. And therefore, dealing with a child with neurodevelopmental disorder like ADHD or autism, a very detailed history is absolutely required. We also tend to use actigraphy in pediatrics like adults, and we'll send children home with actigraphy watches. Actigraphy is like a watch which you can wear on your wrist, and all it does is records movement of your limbs. And when the limbs are not moving, it suggests that the child is sleeping. And this has been very well validated in many studies. And we now know if somebody can wear an actigraphy watch for 15 days or more and then you look at their sleep pattern, we know their pattern. We can see what time they're going to bed, what time they are getting up. And that gives you an idea of whether the child is having insomnia, whether the child is having any particular issues. I think I'll kind of slow down here and see if somebody has questions or if there are particular areas which you want me to answer. I'm quite happy to take.
Thank you, sir, to give the beautiful and knowledgeable lectures and give a panorama vision of the obstetric sleep apnea. It's different from adult to pediatrics, what the investigation protocol and what the difference from adults, and open a new horizon of research of minimum subclinical damage or cellular damage of mild apnea on the body. It's a very good field of research. Now I open this question, further for questioning by the audience to related this field of research or the lecture.
Very well presented, Dr. Ramesh. So my question would be, you said end organ damage. So end organ damage is, as Sir said, it's a very subclinical issue and we do not have markers. So what brings the parent of a child to the doctor would be initially only a backwardness or kind of a slowing down of person's ability to cope. But then after the first consult, usually they disappear. Because when you tell them about sleep study or, getting into the thing. So what is your take? How to actually motivate them to getting to the benefit of, investigating the child further? And how best, as you said, pulse oximetry or an actigraphy, but then how to wear that actigraphy watch for 15 days. So these are, common practical problems. So how do we face them and how do we overcome them?
Thank you. Thank you for that very practical and useful question. I agree. The end organ damage is not felt by the kid initially. The end organ damage that we always worry about in the long run and is a problem is pulmonary hypertension and also quite significant, pulmonary hypertension and systemic hypertension are main and the growth difficulties. But the one primary organ damage which the parents might not realize that it is because of this is cognitive difficulties and scholastic backwardness, which when you take a detailed history, you will probably already see that it is affecting these kids quite significantly. So the only way to motivate, I agree, we also have the same difficulty because first of all, the sleep studies are difficult to come by. The waiting periods is long. Second, it's pretty expensive. And the third is they have to come to the hospital to get it done. So there is a lot of reluctance by the parents to do that. And the way to overcome that, at least in my experience, is kind of have an open chat with the parents and explain to them what we are actually worried about, and tell them snoring, even though the parents came to me with a history of snoring, snoring is not something that worries me immediately, but what is causing the snoring and the effect of snoring that it has on the body, and explain to them how the child's scholastic behavior is going to change. That actually makes a huge difference. You talk to them about pulmonary hypertension, they will not care, but you tell them about that schooling and he is not going to be good in schooling, etc., then automatically there is a heightened thing to do that. So definitely that is something that we do. Second, you asked me about actigraphy, how often we use in the not so much so in the context of obstructive sleep apnea, because it doesn't really help us, but it is usually used in the context of circadian rhythm disturbances, either in an adolescent who has got insomnia or daytime excessive sleepiness, and you want to document regular chronicity and the chronobiology of sleep, then you look at actigraphy. I hope I've answered some of your questions.
Actually, it is, can I answer a little bit about this question?
Sure.
So the neuroplasticities and the synaptic development in pediatrics is little bit different than adults. When the child grows, the inhibitory neurons at the main part is going to develop with times. So when the little bit hypoxia is the most tissues affected in the synaptic development, the child is more active and hyperactivity, as sir said. The most clinical presentation neurobehaviorally. But when we going to adults, the neural development already matured, the synaptic develop, especially in inhibitory types. So when you develop the damaging effect of this minimum hypoxia, you are more slippery and lethargic. So this is the neurodevelopment and the anatomy, the growth patterns of neurologically is the synaptic myelination is the most important difference in pediatric and adults. So, but it is missed mostly in a clinical field. As a geneticist, I have seen many neurogenetic cases which usually clinically present like mostly ADSD or more with the more sleep behavior patterns more severe.
Okay. I agree completely. Thank you so much. Yeah, absolutely.
Sir, just one question more regarding the actigraphy. So, sir, we have the actigraphy that is basically meant for the adults. So, how does a child of 2 years we make them wear that watch, because that is too big for the child's hand?
Okay. Yeah, there are watches which are smaller in size. That's all I can tell you. We do prescribe for pediatric actigraphy watches which are smaller in size. We do not do it in very young children. As I said, we do it in children, preferably 5 years and above, who can understand and they appreciate wearing a watch. The main problem that we tend to have is also these watches which are brought do not have a fancy face and like a watch and things like that. It's quite still medical grade and it is still quite a rugged piece of information. But we give them fancy straps to wear. We put them stickers on it, so children are kind of they are motivated to wear it for a little longer time. Yeah.
So just one more question. Being a psychiatrist, we are getting a lot of patients, children and adolescents with the ADHD. And unfortunately, we never take the history regarding the sleep apnea or the RLS, which have been found associated with the ADHD-like symptoms or mimics. So, sir, in your experience, what proportion of children with ADHD have the OSA? So, if that's large enough, then we should definitely try to include that in our daily practice.
I think it is large enough, honestly. So whether they are symptomatic or not, there are studies. I don't have that immediate reference on me, but I can always send it to you later. I know the number is somewhere between 30 to 40% of children. So it is quite significant, OSA in ADHD. So I think it is important to take a cognition of that. And so what we tend to do is our child, unfortunately, these population of children are not seen by us as pulmonologists, but they are seen by our colleagues in child development unit. ADHD and autism are seen when our kids with neurodevelopmental clinics. And so what they do is they do a screening maneuver, and then they If they are worried about sleep, then they refer it to us for a sleep study. So I will not tell you that we do sleep studies on all of those children. And so if there is a heightened uh, suspicion by the neurodevelopmental physicians, then they refer it to us for sleep study. That's our thing. I don't think there's an easy answer. Thanks.
Hi, Dr. Mahesh. Always a pleasant to hear you in the ear. ADHD and OSA are a chicken and egg story. We really don't know how many of these children are having ADHD because of an OSA or versus the versus the otherwise. So I think it's a very important thing. And also doing a sleep study on a child with ADHD is a nightmare. So there are a lot of problems. I think it's riddled with problems. So I think here it's very important that we look at all the aspects of the neurodevelopment in the child. So if it's clearly an autistic child, or if he has attention hyperactivity, so I feel there the OSA may be there, but that is a primary pathology. But if you have symptoms related to sleep and the child is hyperactive, then I think OSA is the primary pathology. Of course, there are a lot of gray areas here, and you cannot just say it's as simple as this, but it is a very big challenge. And doing a study on them is also a very big challenge.
I agree. And I completely agree with you. And that is why we are also not too keen to do sleep studies on a majority of them, because invariably pulling out all the leads in the night is the main thing that we can witness rather than having a good sleep study done overnight. And so that is a challenge. But hopefully in future, as we go along, we are looking already into it. We are looking at very sensitive sensors which can be placed on the skin rather than as the leads, wired leads that we have got. We are now working, and the world is working towards miniaturized sensors which can be just plastered on the skin wherever, and these pick up multiple uh, mm, uh, signals and wirelessly transmit it to a nearby station which can be uploaded onto the cloud. So those kind of solutions are being looked at, and hopefully in future we will be able to do more meaningful studies in these children with ADHD and stuff. Thanks.
The last question by me, can ask? So I am wearing this 4th generation smartwatch, and I noticed this is a sleep patterns. Pulse. This can be also monitors whole night pulse oximetry, even the saturation, heart rate, everything. So it could be used for like in these disorders in pediatric, because I use on my kid and also I monitor. Then it is working there on him also. So is there any study which utilize these devices?
Many studies. You can imagine it's a huge field. It's a huge data. There is a lot of commercial interest in it. Each company wants to have his own watch. I will tell you the problems. I will go back to technology first. If you allow me, I'll take 2 minutes to talk about technology, and then I will tell you why it is not such a great thing clinically as of today. The technology which these watches uses is very similar to the actigraphy technology, first of all. So they use they call it something as accelerometer, which measures movement. And the smartwatches measure movement in 3 different axes: vertical axis, horizontal axis, as well as oblique axis. So that is number one. Number two, it measures oximetry by using reflective plethysmography, which is not as good as our normal pulse oximetry. The reflective pulse oximetry you would have seen, if you flip any smartwatch, you'll find a green light or a blue light on the bottom, and that, or the red light, and that is the reflective pulse oximetry. Now, the problem with these are, no doubt, these are all measuring vitals and they're all giving you numbers, but none of these companies will divulge how they are interpreting these signals. What is the algorithm that they use for various things? And each company has its own set of signals, its own set of algorithms, which are very different. And therefore, what is true for an Apple Watch might not be true for a Samsung watch, might not be true for a Huawei watch. So you have very different technology which are not united. And therefore, as clinicians, it becomes very difficult for us to standardize all these watches. That is the first problem. The second problem is, because we don't know what the algorithm is, we do not know what is actually measured. And therefore, even though we do encourage patients or parents to continue monitoring, because it will give you a trend. For example, if I am counseling on sleep hygiene, and a child who wasn't sleeping very well is now beginning to sleep well, and the watch shows that your trend is better, then it's good, you can take. But I will not be able to take absolute values. It will tell you stage 1, stage 2, REM sleep, etc., etc. None of it is evidence-based as of today. That's the current status in the world. Thanks.
Thank you, sir.
We have
that's
one
just-
question from online audience. In a diagnosed case of pediatric obstructive sleep apnea, how long should we give CPAP therapy?
Okay, so CPAP therapy, as I said, initially, if you have obstructive sleep apnea and if there's a structural problem, then you consider CPAP. So when you consider CPAP, it's a long-term solution. So we give for a few, depending on for what you start. If I'm starting it for a child with significant obesity, then there is a hope that the child might lose weight. And when there is a more than 10% loss of weight, then there is a chance that I might want to do a repeat sleep study, and if things are better, I might want to decrease it. But if I'm using it for structural problems like syndromic associations, etc., it is lifelong. And I don't think we can talk about just a few months of therapy.
Thank you, sir. So thanks for giving me a nice